try to do is just get a discussion going here with our fantastic panel. I mean, this panel is like a unique occurrence to get these particular 4 people together coming in with all of their perspectives. And you know, really the question that we have is that, you know, as we continue to accelerate technologically, as augmented, I refer to artificial intelligence, you know, still as augmented intelligence. There's nothing artificial about it. It's a completely constructed thing. It augments all of our decisions. But we're living in a world where we have an opportunity to work to solve a particular set of problems. And one of those main problems is the fact that in the United States, we have the most expensive healthcare system by 2x, 2 times more expensive on a per capita basis than any of the other industrialized countries, with outcomes that aren't in the top 25 of these industrialized countries. So we have essentially what one could argue a failed system in which large parts of our population are not benefited by the technologies that we have. And now we have yet another wave of technologies coming in to potentially save the day, where the US will lead in the development of these technologies. But how do we design systems, tools, devices, public health assets, public health solutions that can have the kind of impact that we would like? We have parts of the United States where we have declining lifespan, which is unheard of in our history. We have unbelievable social inequities that are derivative of a range of things, including the advancement of technology itself, which leads to social inequities in terms of access to that technology. So I know that Susan Blumenthal has been thinking about these things for a long time and has been working to help us to design what Jyoti is going to actually be running, which is our new technology for public health schools. So Susan, just give me a sense of what you think is at the root of the system failure in the United States related to public health outcomes. What's at the root of it?
Well, again, thank you so much, President Crow. Thank you for your visionary leadership and for really making educational dreams come true. And, you know, I think helping the university design solutions that address some of the most pressing problems of our time, and health is at the top of the list. You gave those statistics. Public health, you know, medicine treats one person at a time. Public health saves millions of people at a time. It saved our lives today, and we didn't even know it. It's an invisible shield. And because of that, it only becomes visible when there's a crisis. We spend only 3 to 5% of America's $4.9 trillion healthcare budget on public health, on prevention, on preparedness. And yet, 70% of the cause of disease today is linked to preventable factors. So I think it's because it's been invisible, you know, and as you mentioned the statistics, I mean, we rank 42nd on life expectancy, 37th on the health status of our nation. But public health has had landmark accomplishments. If you think about it, in the year 1900, average life expectancy was 48 in America, and 20% of children died before their 5th birthday. So we have a once-in-a-generation opportunity to modernize and strengthen public health with technology, to create professionals who are bilingual in public health and technology, to advance the health of people in America and globally. And I think this is a unique opportunity, and thank you for pioneering this to build the very first school ever of technology for public health to achieve these goals.
Thank you. So Regina, you know, just describe to everybody first, before I ask you a question, what Wellcome Leap is. What is it? What does it do?
Sure.
What does it focus on?
So think of Wellcome Leap as a global DARPA. So the Defense Advanced Research Projects Agency, formed after the launch of Sputnik in the United States, has been responsible for one of the longest standing radical breakthrough engines in human history. Unwin the Wellcome Trust, which many of you probably know, in the US, one of the largest charitable giving organizations devoted to research in human health, looked at the landscape. They said, too much of our work has gotten risk-averse, too slow, too siloed. And they said, we need to form an organization, Wellcome Leap is that organization, to accelerate breakthroughs in human health and to get more of them in service to human health and global health.
So what's an example of a project in this space where you're focused on public health outcomes as it might be related to the emergent augmented or artificial intelligence systems that are evolving?
Yeah, it's striking. There are many examples of the use of artificial intelligence throughout our programs. So in the last 5 years, we've launched 11 programs. We're working in 28 countries globally. And that international work, the multidisciplinary, multi-organizational, multinational work, has really informed everything that we've done. So let me give you just a couple of very brief examples. Let's talk about depression. So 260 million people in the world face depression. In the last 20 years...
At least.
At least about 800,000 suicides per year, at least. Over the last 20 years, we've invested in the NIH alone about 20 billion, still only 1 in 3 people respond. So the question then becomes, what could we do that's different to change that calculus? And here enter the most modern advances in models of models, artificial intelligence. They came from cybersecurity and autonomous driving. We brought them to the complexity of depression. And within 3 years, we were able to demonstrate systems that could reduce the time to an effective treatment for someone suffering from depression from over 230 days to less than 90 days, and reduce the cost simultaneously. Those are the kinds of advances that we're seeing across the board.
Thank you. So Susan, you helped us to, and led a group of experts to help us to design a new kind of school. A school that we didn't want to build was just another public health school, because we felt that not that they weren't doing great things, they have done great things, but that their approach was perhaps too rigid, too narrow, not focused significantly enough on technologically driven solutions. And so just in a short form, what did your group conclude that the country needed?
Well, 4 years ago, as you know, I wrote an op-ed calling for the establishment of a new field of public health technology, because we needed people during the pandemic. We needed to really bring engineers, data scientists, computer scientists, designers, physicists to public health, and create people who are bilingual in public health and technology. I was very honored to chair with Sir Malcolm Grant a group of experts from technology and public health to build a school that would train people in this way to be technofluent, and that they would really be able to create a new set of, a new workforce and a research portfolio, as well as entrepreneurship, to have startup companies that would be able to address some of these problems in public health in novel ways.
Right, so Malcolm, you've been provost at Cambridge, president of University College London, one of the most important universities in the world. You've helped design new higher education systems in France and worked on a number of other projects around the world. You were the chair of the health system in England, which is a $1 trillion or more enterprise involving the entire healthcare of tens of millions of people. So why is it even conceivable that we need new kinds of schools going forward? Why aren't the schools that we have adequate?
Because the whole system's broken. When we talk about increases in life expectancy, which we've seen pretty consistently since the Second World War, although with some gaps in some nations, what has not improved is the health of the nation at the same rate. We read in a big research report last week that of those who have turned the age of 70, 90% have at least one chronic condition. And our healthcare systems aren't approaching chronic conditions anything like they approach acute illness. So of the multi-trillion investment in the US in healthcare, much of that is going into formal systems of hospitals and clinics, etc. But we know that in terms of the overall health of the population, that contributes about 15, 20%, nothing more. The great bulk of unmet need is in public health. And it's related to a decline in the importance, I suppose, of accidents and of infectious diseases as causes of ill health, acute conditions, and the increase in non-communicable diseases, a consequence of lifestyles and complicated other measures. And what we need to do, and where I really enjoy the opportunity to participate in the development of this school, is to ask ourselves, look at all the technology that's being developed for education, what this whole conference is about. Look at all the technology that's going into our hospitals and clinics in uses of new equipment, of new imaging, of new pharmaceutical products. Why can't we get that into public health? How can we develop an entirely new approach, such as that which Susan has been talking about, which grapples with some of these imponderable conditions? understand there's a huge range of variables that we're looking at here. It's complicated to focus on whatever might cause an improvement, as we might be able to do with cardiac disease. But nonetheless, I'm sure that this is a turning point as AI and other technologies come to our aid. But a big challenge to everybody in this conference: how do we turn your attention into this hugely complicated but socially beneficial area?
Yeah, I think people don't really, I mean, it's really, it's kind of funny if you ask people what the leading causes of death are in the United States. They always say, well, cancer and heart disease and so forth and so on, when really, if you took the list of the top 5 or 10 things, about half of them are behaviors.
That's right. Well, 50% of the cause of disease is linked to these behavioral,
right,
lifestyle, and importantly, social, cultural, and environmental factors.
Right.
And we have done so little to address the socio-cultural determinants of health. And I'm thinking, if we can build digital twins of people, with their biology and their genomes and so forth, why can't we build digital twins of communities with AI and link people to the services that they need that are very personalized?
So one of the things, I've thought about this a lot, and I've written about this myself, and this is an area of my own academic interest, and that is, I don't mean to say this in a nasty way, but we're also concerned about ourselves, personally, that we will spend anything, if we have it, to save ourselves, not even realizing that if we spent some fraction of that, we wouldn't even have to worry about saving ourselves, because we would have been protected along the way through our life choices and other things, our decision making and so forth. And so years ago, I was asked to write this design analysis of the National Institutes of Health. I had only 2 weeks to do it. It appeared in Nature magazine and in the Boston Globe newspaper, and I said we didn't need 27 institutes in the National Institutes of Health. We needed 3 institutes. One institute that understood everything there was to understand about biology and health and so forth and so on, as well as human behavior. Another institute focused on how to produce technological solutions that would be available to everyone in the society, not just the rich, which is the case that we have right now for individualized health. And then a third institute that would focus on nothing but lowering the cost of healthcare. The U.S. economy is hampered because we're spending 20% of the economy on healthcare when other competing economies are spending 10% on healthcare, leaving 10% to spend on other things. And so, turning to you then, Jyoti, so you're sitting over there at Cornell University, minding your own business, and you're running the whatever entrepreneurship in population health sciences at Cornell University, and wow. And so then along comes this idea of this new school, technology for public health, as opposed to just a public health school. Let's design it from scratch. We've hired you as the new dean. It doesn't show up on your thing here because you don't start till like July or something, but nonetheless, why would you leave Cornell University to join a pack of crazy people at ASU to launch an entirely new school designed by Susan and Malcolm and her buddies to launch off in a new area and maybe someday, work with Regina on a big grant? But I mean, why would you do this? What is, you were completely safe and secure sitting over there.
Is it unsafe at ASU?
Well, we require double belts in the front seat of the car, not just a single belt. So,
well, thank you. Good morning, everyone. First of all, it's really an honor to join my esteemed panelists here. I think President Crow said the right thing towards the end, that a key goal, my own personal goal, and I think what we want to achieve as part of this new school, is to really see how we can enable technology-based solutions to make public health personal. We are part of the public. We contribute to the public health agenda for our communities and for our country. And so how do we envision technology as an enabler to achieve that objective? If you look at, we've been providing a lot of statistics this morning. It's probably some of you are still in the first cup of coffee. But I'll just throw one more number here. By some estimates, in the US, we spend roughly $11,000 per person per year on healthcare delivery. $11,000. Can you guess how much we spend on public health?
$20.
Times 10.
$200.
About $200, $250, right? That's the estimate. And we can, I think, all attest to that prevention is always more effective and more better than cure. But why don't we actually invest so much on prevention? Well, I think there is clearly lots of policy elements to it. We are not necessarily incentivized just by the way how federal and local and state policies might work. But at the same time, I think the tech industry in general, when we think about health tech, we are predominantly discussing healthcare tech or med tech. We're not so much focusing on public health tech. And so I think that is what we really want to fundamentally
So just
change.
to help everybody, just give me, you or Regina, give me one example, or Susan, give me one example of a public health technology that has worked or should work, or we should, just to help the audience understand what we mean by a public health
Do you
technology.
want to maybe talk about the example?
And then we'll come back to you,
The
Jyotishman.
communication one, yeah. So we have a very good example. In 2021, we did an experiment. It was took us a couple of months to get the experiment done, and we asked the question. This was in the time when, from a public health perspective, we needed people to understand how to make good decisions about vaccines. And we asked the question, what would communication around public health look like if we used some of the technology that was very common in the advertising industry, in the tech industry? And so just to calibrate you, in the 70s, the average US consumer saw about 500 ads per day. Today, that number is about 5,000, so about 10x that number. And so we looked at how public health communication was trying to break through that very large sea of information and how we could shift our understanding of how to do a better job. So what we did is we created over 300 different types of messages surrounding the information about vaccines. We delivered them on various platforms. We did, in 1 week's time, 57 million impressions, 45,000 engagements. And what we discovered is that when we approached it that way, the messages got through usually between 25 and 43% better than the traditional public health messages. This is how people experiment now to find ways to communicate so that they are effective in the populations. Now, the most interesting thing about that was that we took the best performing messages and the worst performing messages, and we gave them to 40 marketing executives, and we said, you choose which would be the best and the worst performing messages, and they did worse than a coin flip. So the thing to understand there is that's how people approach, in the tech industry, that's how they approach communication about products, about services, and so on. We need to use some of those learnings for public health communication as well.
Let me give you another example, wastewater technology.
Quick example, yeah.
Wastewater technology. At the outbreak of the pandemic, there were scientists who developed, entrepreneurs who developed this new technology. They went to the CDC. The CDC's traditional toolbox is epidemiology, statistics. And they said, we don't do this. But wastewater technology...
We were one of the places that went to them from what we called our crap lab, but go ahead.
But what it did was it's the potential to detect outbreaks 3 weeks before they happen and to model. And so this is an example of a public health technology that works.
Right. So Jyoti, then back to you. So why leave, and obviously at Cornell, you're sitting there and the money just ends up at your door and the hallways are lined with gold. And and all your students are obviously geniuses or they wouldn't be at Cornell. So why, I'm being facetious, so why try to launch this new school? What do you want to achieve with this new school? And then we're going to turn quickly to AI. So,
yeah, I think as part of this new school, again, we want to see how technology, and I'm using technology in a very broad sense, AI, machine learning, digital health, and so on, could first of all allow us to better understand what are some of the existing as well as emerging public health threats. Right now, if you look at, for example, broader public health infrastructure in this country as well as globally, we are still using PDF files to share data. There's huge data modernization initiatives across the country, but it's not there yet. We're still training our students and learners in the silos of biostatistics and epidemiology, and not necessarily enabling cross-training opportunities. And so I think as part of this new school, we want to break down these silos, really have interdisciplinary programs where it's not just people who are engaged in public health and medicine, but how can we engage with experts in the field of communication, How can we engage with experts in the field of law and public policy so that we can think about public health and public health technology in a more holistic view?
So I'm going to ask this little AI system a question, and then the avatar that I picked for the answer will then give us some answer, and then that will lead to other comments from our panelists. And this system that I'm using is FYI.ai, which we have 2 panels later on, which is available to all of you at no cost. But I just picked this particular avatar, so hold on. So give me a sense, if you can, of if you were designing a technology for public health school as opposed to a regular traditional public health school, and you wanted that technology for public health school to take advantage of all of the new fantastic large language models that are out there, all of the AI systems that are out there, what would this school do and how would it operate? And what would you recommend this school really focus on to really help us get better public health outcomes in the United States specifically? And don't give me any of your mumbo-jumbo answers. What I really want is I really want to know, how are we going to do this? So give me 3 specific recommendations. It's a big problem. You know, it's not working. It's too big of a problem. So
That's why we need a new school.
Well, while she's thinking, Jyoti, what are you going to do about AI while she's still thinking?
I think we want to embed AI in many different aspects of the educational programs that we're going to offer. Just this particular fall, we are going to launch 2 new programs, an MPH program and an MSPH program in public health technology. And as Dr. Blumenthal just said, we really want our learners to become technologically fluent. Whether you are coming from the field of STEM, computer science or information science, or you are a traditional public health learner, we want you to understand the dual aspects of these dimensions. And I think a key part here that often comes up is that is technology going to inject more bias and disparity into our ecosystem? And I think that's a very valid question, and that's a very important question. And so we, again, want our students and learners to think from a fundamental computational research point of view. As you are designing LLMs and as you are designing other tools, we want them to learn how to actually study bias and ideally try to de-bias these systems. But also at the same time, when we are thinking about implementation of interventions at scale, how you are actually working with community and members of the community. Public health at the end of the day is about the public. So you have to listen to their needs and work hand in hand. So that's where the whole socio-technical part really comes into play.
Yeah, so it's telling me I went to SOS, so I lost my signal strength here. So if I can get a Wi-Fi signal, or somebody can give me Wi-Fi, then maybe we can figure out how to get the answer. But I think that people, they're not fully grasping this concept of, yes, we're underspending in public health areas where, we're spending massive amounts of resources on, photon beams for this and this and this and this and fractional expenditures. But how can an AI system be used and applied in ways in which it can help a regular person make decisions? So I'll just open that up for all of us. How can that now? I wear this Fitbit. I've had a Fitbit for 9 years, and a few months ago I started getting this irregular heartbeat. So then I tell my doctor that I've got this irregular heartbeat, and so then I go in, I see the cardiologist, and the cardiologist says, you got to do this, and you got to do this, and we've made these adjustments to take care of it. And so it was driven by this thing. And so then I took every sentence that this cardiologist told me, and every bit of data that was made available to me by the Mayo Clinic, and I put that into my own AI system and built my own model of understanding. And I'm probably not a regular person in that sense, but it's literally unbelievable the amount of information being provided to me by this little wearable device, and probably was helpful at addressing this now solved little heartbeat problem I had. And so how's all this going to work?
Well, I think you've identified that, medicine is harnessing this for treatment, because as Hippocrates says, but as Hippocrates says, prevention is preferable to cure. So what you're talking about, I think, is taking that data, making a twin of yourself with the data, and then looking into the community for what else is going on there, that AI can help map individuals as well as community services and link people to the services that they need. I think it also is being used for predictive modeling to see where there are outbreaks in communities and then create interventions that will be helpful. AI will help us in terms of training people. I mean, there is a shortage in the workforce for public health. So training people and collaboration across the town, across the country, across the world.
Yeah, I can add a few things on both training and access, right? So I think the example that you gave is a really good one of how simple signals, but tracked very incrementally and continuously, can give us good indications of change. And change is often a very important signal in understanding someone's health. There are other aspects here that fit in the entire suite of problems that we need to solve. Training, you spoke about, Susan, for a moment. So here, we're starting to see really interesting advances on the training and educational side. Let's just take the particular example of training surgeons. So training surgeons is very difficult. We lose about 1.5 million people annually to just lack of access to basic surgical care. We don't train enough surgeons to meet the need. Access is a real issue. So what we have developed are...
And I bet most of those people that are dying are from the lowest income profiles.
Yeah, or in rural settings where they can't get access to care. This is true not only in the United States, but globally. And so what we know is that the presence of a simple box trainer can reduce post-operative surgical complications by as much as 16%. That's good. But we also know that we train pilots using very advanced simulation techniques, and that has reduced pilot training by about 50% in time. And we can then train surgeons so that they can do emergency procedures and so on. We train pilots so that they can do emergency procedures and so on. What if we could do that with surgeons also? Generative AI has allowed us to build the first ever surgical training simulation environments with real tissue images generated by AI that are almost indistinguishable from the real tissue images that surgeons see. It's really remarkable. Generative AI is allowing that to be possible. And there's all sorts of other access problems that can be solved with some of these advanced artificial intelligence techniques.
I think also virtual reality. I mean, President Crow, you're using this for teaching biology, but virtual reality.
But you can all see here if you go to the Dreamscape Learn exhibit.
Which is quite extraordinary. And I think virtual reality can be used to simulate outbreaks and interventions to prevent them or to respond. Crowdsourcing, getting people to put together their ideas and surface innovative solutions. And then gaming. I think there are, 50% of kids are involved with games today. And they're often war games. I think if only we could harness your talents in educational tech and create games that are promoting health and mental health and resiliency. I think that's a challenge. So I think there's a number of arenas where tech can be used to really promote the public health.
Let me see if I can get this to work. So I got on this Wi-Fi here. So here's the question I wanted to ask. So I'm designing this new technology for public health school. I want to maximize AI tools, artificial intelligence, augmented intelligence in this AI school. How can we do something with this school that would have maximum impact using AI technologies? How would the school design be different? Why is this something important to do? And give me 3 cautionary notes, just to change the question. Give me 3 cautionary notes. You see, Bio, I'm still not getting it to work. So anyway, you guys can go to this, fyi.ai, and you can, if you find a Wi-Fi that works, you'll get it to work. So anyway, so let's just go back to AI again, just in terms of how are we going to have the school curriculum be fundamentally different than the other public health schools that are out there? I mean, what is it going to do?
I think a key component as we are building our curriculum is to precisely break these silos. We want to inject, we want to allow our learners to have fundamental expertise in programming and computer science, but not necessarily for them to become the best Python programmer. But for example, how could you use prompt engineering and to develop models that would allow, for example, to predict a risk of certain outbreak? How could you think about virtual reality as a means for training lay individuals in administration of naloxone? There is actually a very nice project that was done in Richmond, Virginia, where the public health system collaborated with a startup company to design tools that would facilitate drone delivery of naloxone kits. So as soon as your 911 call comes in, it is GPS tagged, and a drone takes off with the naloxone distribution kit, which the idea being that bystanders could actually administer naloxone before EMS would arrive. Right, so that's a very practical example that requires team science and team-based collaborative efforts and case-based studies. So these are the elements that we are going to incorporate in our program.
So Malcolm, at NHS England, what kinds of things would have been most useful to enhancing healthcare outcomes among the tens of millions of people?
That's a huge question. I would say one of the things we should be welcoming is the forthcoming retirement of one of the world's greatest doctors, and that's Dr. Google. Dr. Google is going to be overtaken by Dr. Agentic AI. I think we're going to be able to see an ability for people to, just as you've been trying to do there, Michael, is to use an agent like FYI to say, help me develop my diabetes management plan. Just here are some of the problems. Here are the tests that I can feed into the system.
Here's my data, right?
Here's my data. Help me develop this. And I think we can cross over. I remember about 20 years ago, Vinod Khosla stood up at a convention of doctors in San Francisco, about 2,000 of them, and said, you're all redundant. You know, we only need 20% of the number of doctors that we've currently got because technology is going to come in. Now, he was an early prophet, but I believe that much of what we can change in the NHS and in the United States of America is breaking down the medical care silos and giving much greater agency to individuals using these technologies.
Yeah. I can offer a very specific example and in the near term. So stillbirth is a real problem in the world. If you're not familiar with this problem, every 16 seconds in the world, a child is born still. That's 2 million babies per year. Now, most people think that's a problem somewhere else. But in the state of Arkansas, there are 37 maternity care deserts, 37 counties that are maternity care deserts. The stillbirth rate in Arkansas is twice that of the best state in the nation. The maternal death rate is 3 times that of California. So now we look at that problem and we say, what can we do? This is largely an access issue. So how do we accelerate research in stillbirth to get the breakthroughs that we need, and then also make the tools necessary to prevent stillbirth available to greater portions of the population? And I'll give you a very specific example. In the particular program that we ran, in the course of the first year or so of the program, we collected over 250,000 images. These are ultrasound Doppler waveform images. Normally, that would have taken a year to analyze. We did it in 1 hour with an AI strategy. First step, acceleration of the research to the breakthrough. Second step, if you want those ultrasound analyses to be done at scale and solve the access problem, it cannot be only in the hands of an expert sonographer. We need the AI strategy to get it in the hands of a novice sonographer so that we can get it to more people. Those are the kinds of advances we are going to see one after the other using these strategies.
And to underscore what you're saying, I mean, this is a new field, public health technology. Just like bioengineering emerged after World War II to solve some of the health problems that became visible at that time that we didn't have solutions for, so this new field is going to develop with Jyoti's leadership, you know, in the kinds of solutions with AI and other technologies, because it's to build the devices, the programs, the initiatives that are needed with AI and other emerging technologies to make a healthier Arizona, nation, and world.
So we're down to our last 11 seconds, according to this small clock in front of me. And so I think the last point that I'll make is just that this is a fantastic group of people who are doing everything conceivable to advance the somewhat slow and encumbered, yet unbelievably successful. This is the hard part about the design of academia. It's done so many things and achieved so many things and done so well, but it's achieved those things and done so well in ways in which it then also simultaneously creates these outcomes which, at least in the United States, end up being unfair in the sense that if you don't have resources to afford the proton beam technology or the maternal health care for your fetus as it's growing in your body, well, too bad for you. And it just can't work that way. So we have to find a way to help build a healthier country and a healthier world by advancing and changing not just the technology itself, but the way we teach, the way we learn, and the way we discover. So let's thank the panel.
Thank you.